Welcome to another episode of Follow the Brand TV. I am your host, Grant McGaugh, CEO of 5-Star BDM, a 5-star personal brand and business development company. I want to take you on a journey through another deep dive into the world of personal branding and business development using compelling personal stories, business conversations, and tips to improve your brand. By listening to the Follow the Brand TV series, you will differentiate yourself from the competition and build trust with prospective clients and employers. You never get a second chance to make a first impression. Make it one that will set you apart, build confidence, and reflect who you are. Building your 5-star personal brand is a great way to improve your skills and knowledge. If you have any questions for me or any of my guests, please email me at grant.mcgaugh@5starbdm.com. Now, let's begin with our next episode on the Follow the Brand TV.
Five-Star BDM, Brand Development Masters, is a professional consulting and advisory group keenly focused on business development services for the small to mid-sized business and entrepreneurs. Although every business is unique, they often share business development challenges that can be addressed through smart branding. Services include process improvement and operations, digital strategy and transformation, business intelligence, digital marketing, and personal branding. Our business and personal branding company has helped a number of professionals and organizations to optimize and grow. This results in more business, more opportunities, better reach, positive outcomes. Visit www.5starbdm.com today to learn more.
I was able to speak with over 1,000 patients from all race and ethnicities. And I came to the concept of recognizing that solutions are simple, and if we solve the simple, it doesn't have to escalate to the complex. After hearing the presentation of Dr. Beverly, will it change the way you engage patients? And 90+% said yes.
Welcome, everyone, to the Follow Brand Podcast. I am Grant McGaugh, and I get an opportunity to bring back a very, very popular guest, Dr. Maureen Beverly. She was on our show about a year or so ago. We gave just a great discussion around sickle cell, around how to work with patients when you're not culturally competent about some of the people that you're working with. Now she's writing a book, and the book is coming out very quickly. I think it's going to be announced here on Juneteenth, as a matter of fact, and that's going to be wonderful. And so I want to bring her to the stage, talk about why she wrote this book and why it's so important. So Dr. Beverly, you'd like to introduce yourself?
Thank you, Grant, and I'm honored again to be on your podcast. So my name is Dr. Maureen Beverly, and currently I'm a consultant in a consultant role. I'm a consultant for Maureen Beverly, MD, PLLC, Patient Engagement and Cultural Competence Training. Prior to my current position, I was at three public hospitals in New York, which was Elmhurst and Queens, and King's Hospital, which was part of New York City Health and Hospital. And I was responsible for developing the first care management program. And within that care management program was the concept of the bridge team. And the whole idea about the bridge team, bridge the gap. I don't care what the gap was, it was an opportunity because the bridge team would have a little extra time to speak with patients and families to be able to better understand who they were as individuals and what were some of their concerns. And the bridge team was amazing, and it was a combination of care managers, case managers, social workers, and myself. And because of the care management program, I was able to speak with over 1,000 patients from all race and ethnicities. And I came to the concept of recognizing that solutions are simple. And if we solve the simple, it doesn't have to escalate to the complex. And I will go further into some of the solutions, the simple solutions, and how we came to have that concept. So in Elmhurst, it was a large, more diversified population. There were Asians, Hispanic, Indian population, and a growing Russian population there. The Black population there was very small as compared to Queens, where there was a large Black population. And the second population was Indians, but they were not from India, they were from Guyana, they're Caribbean, you know. And just on a side note, I came up with the concept of the lookalike syndrome. And what do I mean by that? So we went in to see a patient at Queens and the bridge team, and one of the nurses said, "Oh, so where in India are you from?" And he said, "I'm not from India. I'm Caribbean. I'm Guyanese," you know. So that's when I realized that what I call the lookalike syndrome. When I do presentations, which I've done at various institutions and medical schools, and I said, you know, go tell a British person they're Irish and see how far you get. Go tell a Chinese they're Japanese. Go tell an Indian they're Pakistani. Go tell a Jamaican they're Trinidadian. And go tell a Nigerian they're Ghanaian. And most important, go tell a New Yorker they're from New Jersey. You know, and I think that's important because in the same geographic locations and there are similarities, but from a patient engagement and a cultural competence perspective, we need to understand the unique differences when it comes to healthcare and be able to have a conversation with patients. And as I said, in my various roles in New York City Health and Hospital, as Associate Executive Director, I developed the first care management program. And when I was Deputy Executive Director at Kings County, which is in Brooklyn, New York, and it's what I describe as the merging of the African diaspora. There was a large Caribbean and a large African American population. And the Hispanic and the Spanish population was not from your typical Puerto Rico, Dominican Republic, or Mexico. They were from Panama. And under colonial rule, the British sent the English-speaking Caribbean islanders to Panama to build the canal. Phenotypically, they look Black, and their names are English and Spanish. Their names are not Maria Rivera or Jesus Garcia. Their names are Ronaldo, Austin, Antonio, Martin. And their primary language was English. And the Caribbean population in Brooklyn, the top islands were Jamaica, Trinidad, Haiti, and Guyana. And so the second language outside of English was Haitian Creole. You know, and it's based on my talking to over 1,000 patients from all ethnicities that I came to the concept of simple solution, and it was a result of what I refer to as stopping my tracks moments.
This is so important to understand this. You have a unique perspective on health equity. I mean, your book that you've written, 9 Simple Solutions to Achieve Health Equity, a guide for physicians and patients. And in our previous discussions, and you just alluded to it right now, that we've got to understand the people more than or just as much as we understand the disease, because of how needs to be treated and you get better outcomes. Talk to us more about what you've learned when it comes to health equity and your particular take, and how you feel this will be a solution for physicians, especially if they read your book and can get better outcomes.
Yeah. So just a correction, the book is entitled 9 Simple Solutions to Achieve Health Equity, a guide to healthcare professionals and patients. Not just physicians, it's everybody in clinical, could be social workers, could be nurses, and so forth. I think from my perspective, my understanding of individual human beings and the value of individual human beings from all ethnicities and race. Because if you don't value me, my healthcare is going to go south. But if we have a concept of what I define as the common thread, the human experience, and what do I mean by that? Once accurately diagnosed, there's no human being on planet Earth to give it back, regardless of race, ethnicity, socioeconomic status, language spoken. The billionaire can't say, oh, I'll give you $1 million to take the cancer back. Oh, that's not enough, I'll give you 5 million. It's the same circumstance as a billionaire, as a homeless individual. It's non-negotiable. In life, we make changes. We can make changes. You know, if we don't like our school our kids go to, we could change. If we don't like our jobs, we could leave. If we don't like our family, we could go to another state, you know. But once accurately diagnosed, it's non-negotiable, period. There's no culture that says, oh, in our culture, we don't accept diabetes, you know. So maybe health systems would be more empathetic and less judgmental if they recognize the concept of the common thread. And for us also to recognize the bulk of us taking care of patients never laid in a hospital bed. Those that do are women delivering life, and in certain circumstances, patients are trying to prevent death. And so to me, that's the common thread. That's one of the simple solutions, adopt the common thread. And so it will also increase the value of the human being, particularly the African-American population, who are less than considered in the same category as being valued as a human being.
If you can figure out a way to network, connect, create, and get your 5 to 10 minutes of FaceTime, they're happy to receive it. I'm happy to receive it. But make sure that what you have to say is impactful. Community is what raised me. A song that said, you can do anything regardless of where you're from, regardless of where your upbringing, we support you. I think the differentiator with us is that we have truly leaned in on culture. Culture is what keeps people. Something that I learned very early in my career, thankfully, is that if you're always chasing a higher salary or you're always chasing a title, you're gonna find it. If you go out looking for a higher salary, you're gonna find it. If you want a bigger title, you're gonna find it. But culture and the way that you feel when you step into the hospital, the way that you feel when you step into your workplace, that you're not going to find everywhere.
Selena Velasco-Holson. I am a Chief Operating Officer for HCA Florida JFK North Hospital, which is a HCA hospital in the East Florida division as part of HCA's network. I've been in my role for about 1.5 years now, and with the company for 5 years. So I'm really excited to share some of my learnings and my journey with you all and the audience today. I have three pillars that I live my life by, Grant. And I think that what's made me successful has been operating by these three, which is being empathetic in nature, holding your team accountable, and being authentic to who you are and yourself, right?
Now, you also mentioned, and you just spoke about it, stop in your track moments. And, when I see that, I get this image. I can see myself, on my daily commute or whatnot. And then you have that stop in the track moment. You get that one call or something occurs. It just changes everything in life and what's important. Talk to us more about what your experience is when you say stop in your tracks. Can you explain?
Yes. I give you an example of what I referred to. So the bridge team in Queens, we were told the most vulnerable population of is patients with sickle cell disease. So we were told to, look, go see this 18-year-old. She is just attitudinal, disrespectful. She's always in the emergency room, readmitted, and so forth. So then, I'm thinking, what 18-year-old is not attitudinal without a life-threatening condition? And let's give her the benefit of the doubt. So the bridge team and I, and these stop in my tracks moments always happen at Monday morning, 9 o'clock. So we were about to enter her room, and Grant, the statement is forever embedded in my brain. She went like this, I'm on my phone, okay? So the team is whispering, that's what we're talking about. She's so disrespectful. So I said, give her the benefit of the doubt. So when she got off her phone, we're about to enter the room. And here is her statement. If you have a cure, come in. If you don't, and she pointed, keep walking. And I was I expecting that Monday morning, 9 o'clock?
Yeah.
So I literally remember putting my foot back on the ground. And then the next statement is I became the child and she was the adult. Why do I say that? She said, did you hear what I said? I'm going to repeat myself one more time. Isn't that what we tell our children when they're not following directions? If you have a cure, come in. If you don't, keep walking. And I said, I had no idea what to say, to be honest with you. Then I finally said, I don't have a cure, but let me think about what you said and I'll come back and speak with you. I went back to see her 5 o'clock that evening. This person who I met 9 o'clock Monday morning from my perspective, is an individual who the system created. When I went to see her in the evening, this is who this actual person is. She was very analytic, very thoughtful in her conversation, and very honest. And she said another powerful statement. She said, "You doctors don't teach me about sickle cell. Sickle cell teaches me." And I said, "Tell me about it." And she was 18. At 16-year-old, her mom got off the bus from work, developed chest pain, and taken to a hospital and died of a heart attack. At 17, her sister, who was admitted for sickle cell crisis and sepsis, died in a hospital. She's now 18, and she lives with her uncle. And, you know, the way she describes him, he is a food, clothing, and shelter type of guy, you know. And I said to her, "Have you ever been referred to a therapist for depression screening or to speak to a therapist at all?" She said, "No." And we hugged each other and literally teared up, you know. And she was the stop in my tracks moment, an example of that led me now to go directly to the head of the emergency room and develop a program for when patients came in with sickle cell. We would need to have a sickle cell support group. And if they agreed to be a part of the support group, sign them up. And that's what happened when we signed up patients for the adult sickle cell support group. And we had the meetings once a week at 12 o'clock lunch. We provided lunch, and it was an hour before hematology clinic. And when you heard the stories, it was humbling. And there was a therapist on the team, there care managers, case managers, social worker, and a therapist, and myself on the team, as well as this patient. And it was unscripted. Patients could say whatever they wanted to say, whatever their concerns were. And I heard the word hate a lot. And I said, "Oh my God." So one of the patients says, listen, it was very touching. She said, "Oh, I hate my mom." I said, "Oh my God, as a mom, how do you hate your mom?" She said, "Oh, no, I don't hate her now. I know she loves me over the moon, and she wants me to just don't have any more pain. And she cared about my health. But I never understood when I was younger why she sided with the doctors to keep me in so much pain. Why didn't they just let me die?" You know, and then the other last story about the hate. My brother hates me. "Why does your brother hate you?" "Because I suck up all the oxygen in the room." I said, "Tell me more, explain it." And she said, "Well, she had sickle cell, her brother did not. And so in a family where one has a life-threatening condition and the other sibling does not, it can create conflict." And so she said the brother was on the basketball team and the team never went anywhere. All of a sudden they made it to the semifinals. Let's say the finals is tomorrow. At 1 a.m. in the morning, she developed sickle cell crisis, and the mom and dad had to take her to the hospital. And he had to go to the game by himself. And that's when I realized that there was no family counseling offered to patients with sickle cell disease. And it should be a mandate, you know. And currently, patients with sickle cell, the adults, they're living midway through their life expectancy now, and they have to consider themselves sickle cell warriors. And everybody thinks it's a great term, but I have a problem with that term. If you have a life-threatening condition, why do I have to be a warrior? What does it tell you about the health system? Patients with cystic fibrosis don't have to be warriors. Patients with leukemia and other cancers don't have to be warriors. So why does this population have to be a warrior when they're midway through their life expectancy? But I'm happy to tell you that the sickle cell support group is still in existence today. And now it's by Zoom. You know, after COVID, it's by Zoom. But we have changed the dynamics, and elimination of the word drug seekers was eliminated from the emergency room, and the head of the emergency room then have a physician assistant who saw patients. And I've developed a whole transition of care process from adolescents to adult. The last thing I'm going to say on this is, I know the time is of the essence, is that, do you know, there is in the literature, there are patients in their 30s who still stay with the adolescent docs because they don't want to go to the adult, so because they're treated so poorly. And my last statement is from Dr. Zemsky, a pain specialist in Connecticut. He said, difficult patients are not just born. Sometimes they're created through the medical system. Not only the system failed to cure, it may have done unpleasant things to make matters worse. And So that's one of the simple solutions that came about as a result of this individual, with, as I say, stop in my tracks moments.
That's a great stop. You stopped me in my tracks because at first it taught me that you're a great listener, that you listened and truly uncovered the story and the underlying root causes of certain situations. As you said, you couldn't solve sickle cell, but you obviously could solve some of the other effects that occur when a person has this type of disease, the impacts around family, around relationships, around, isolation and that type of thing. I think you did a fantastic job of talking us through that. Now, you talk in your book, you say 9 simple solutions. You just gave us one simple solution. Now, is your book about 9 steps? Is it more around different stories and experiences? Tell us more about what your book is about.
I think the 9 simple solutions, one of the major solutions is, one of them was the common thread, accepting the common. The other is the negativity in the medical records. I'm sure you heard the word non-compliant about 20,000 times. So now there's a nicer word, non-adherent. But how many times have you heard the associated why? So we don't know why John Brown didn't take the medication, but we're going to refill the same medication he didn't take and call him non-compliant. And non-compliant written in the medical records 2 or 3 times, that patient is under the help bus. And nobody cares about them. So whatever happens, it's their fault. And there's an article came out from, I think, the University of Chicago Medical School, where an article on non-compliant. And in the article, it stated that it was more geared towards African Americans, particularly males. But there was no why in that article. And in my team had to ask why. Why doesn't somebody follow directions or take their medication? Because if they didn't know, they didn't know why, they said, we got to ask why. Dr. B's that's what they call me, Dr. B. Dr. B is going to bug out, So I'll give you a typical story. And when we ask why, these are patients with heart failure. 60-year-old African-American male recently diagnosed with congestive heart failure, returns 2 weeks later, heart failure decompensated due to non-compliance. So when that patient gets admitted up to the unit, is anybody going to care about that person? And one of the nurses in the unit said, oh, so he just got diagnosed with a life-threatening condition and doesn't follow directions. I got other things to do. My team had to ask why. And I'm glad you're sitting down, Grant. So when we asked him why don't you take your medication? I can't take the water pill, which is a diuretic that flushes fluid out of the body so the heart could pump better. And it makes you urinate a lot. Why can't you take the water pill? Because I drive the number 7 train. So you can't say, oh, the train is delayed because the driver has to find a bathroom. So we said, when is your shift? 11 p.m. to 11 a.m. What do you do when you get home? I do my chores. I make breakfast. I take some of my medication. But if I'm on my tour, if I'm going to be on my shift, I don't take the water pill. So we brought in the same cardiologist who was ignoring him as well. And that's what I'm saying. You could change systems, culture, And he said, okay, take the water pill when you get home, but be aware it may wake you up during the sleep. During your shift. It may wake you up during the day when you take a nap. But if once you get to your shift, you'd have less of a reason to urinate. But to the degree that you do, we're going to give you a cubicle. So you could use in the private space when the train stops. Mm-hmm. And you know what the patient says? If I knew I had to choose between peeing and breathing, I would have chosen breathing.
Yeah.
Just expand the conversation and the concept. So, without the why question, he would have been readmitted multiple times. And the more he gets readmitted, the more people are going to ignore him and be judgmental. And if he were to pass at mortality, it would have said died due to non-compliance. A simple solution, ask the why question. And I tell patients, and I give instructions in my book, if you're in the hospital or your doctor's office or wherever you are, and a doctor asks you, did you take your medication or did you follow direction? And wait a couple of seconds. And if you don't hear the why question, say, do you want to know why I didn't take my medications, let's say. And then I instruct, and I really want patients to really follow this because I think it could be a change in health system. And then the next statement should you, please don't write non-compliant in my medical records without asking me why, because it could have a negative impact on my health outcomes. Thank you.
Man, who's your favorite podcaster? Man, Grant, man. I love Grant's podcast. Well, who's Grant? I'm going to send you the link. I love Grant.
Follow the Brand TV broadcast host, Grant McGaw, as he visits with top executives and entrepreneurs to find out their secrets of success with their personal brand. Follow the Brand TV broadcast host as he focuses on brand development to build better relationships, bring value to your business, relationships, and career. You will enjoy listening to each episode that is tailored to speak to you directly. If you're looking for this type of clarity in terms of building your brand, you have tuned into the right station. Each episode will help you to shape a conversation in the 5-star BDM network of 20,000 professionals and become a springboard for your corporate engagement and business opportunities. Each guest will frame their story in the areas of personal branding, business development, career development, financial empowerment, and technology innovation. Grant McGaw explains why he is the CEO and owner of his own professional career. Grant is an accomplished business leader and entrepreneur who wants to give back to individuals to grow their personal brand strategy. Tune in as he weaves his story about new possibilities, while to you exceed expectations. If you love storytelling, this show will make for fun.
That is so important to understand that. That's a big question. Why? I think most people would choose breathing over the alternative. And if they are not compliant, I think that what you just brought up, a simple solution, ask why. And there's a lot of reasons.
Yeah.
And once you find out those reasons, maybe now you do have some solutions that you can implement that will be much better. I really appreciate you saying. I'm interested now in your journey of writing the book. You have been a requested speaker. You have done a lot of different webinars. You have been involved with a lot of different clinicians, physicians, and nurses. And I want to know your journey of writing this book. What was that like? I mean, was this over 5 years, 3 years, 1 year? Tell us a little bit more about that.
I think it probably was over, probably started in 2019 at some point, and it took different paths, and since I'm a new writer, I've never written a book before. So I joined a lot of webinars to understand the process involved and the chapters, and it was interesting. And the editor that I got, she was amazing. She was Dr. Irene Duanka. She was Chief Medical Officer at IBM, and she was on a webinar. And so I connected with her and I told her about my book and would she be interested in editing my book? And she said yes. And so and because she wrote a book she edited a book on clinical trials and disparity. So I just thought she would be a good, excellent person. She understands the medical field and she's also an editor. So how better could it be? And she was amazing. And she introduced me to a lot of different ways of approaching certain topics, And so I'll just give you an example. So there was an Asian mom when I was at Elmhurst, and I passed her, and a baby was in the NICU, and my office was about the next door. So I said, she looked so sad on her face, and you could see the sadness and the pain and the suffering. And she said, I said, which one is your baby? So she pointed to her son, the baby. Long story short, the baby had a cardiac surgery at Mount Sinai with the affiliate hospital. And so now they brought the baby back, and a week later, the baby has to go back to Mount Sinai, and she did not know why the baby had to go back. And obviously, the feeling about it was that the surgery went bad or something went wrong, and she resonated with me. I felt her pain because, and a chapter is in my book about my son at 17 months who had brain surgery, and so as a mom, so I went into the team and I said, please explain to her why the baby has to go back, So the team said, oh, we're waiting for her husband. And I'm glad I said, oh, he must be parking the car, So they said, no, this is 8 o'clock in the morning. He'll be back at 6 p.m. from work. I said, what? You're going to wait for 12 hours for her? So I said, no. He said, in the Asian culture, the man makes the decision. So that's what they're waiting for. Mm-hmm. So I said, no, the mommy culture rules. Okay, regardless of where you are, the mommy culture rules, race, ethnicity, doesn't matter. The mommy culture, let's go explain to her and let her tell you to wait for her husband. And one of the corrections that she made, which was interesting, she said, well, in all cultures, the mommy culture doesn't rule. So, that was, so I changed it to, in hospitals, the mommy culture rules. But this is just shedding light to a wider audience, So she said, well, I don't know if the mommy culture rules all over this land, So these are just, yeah. But
like I say, cultural competence is such, you can get a PhD in cultural competence. And it's so important when you marry that together with healthcare. And you're talking about health equity. And you're taking such a different lens at looking at health equity. A lot of people, you think health equity, you're talking access, you're talking affordability, but you're talking about it from a cultural standpoint, that if you have to go through some type of hospital admittance, or you're in the doctor's care and the care team doesn't truly understand you, whether it's from a language standpoint or from, like you just mentioned, the cultural standpoint of how they view certain things, and there's a disconnect, there's a gap. And you've done thousands of interviews now. You've seen the outcomes of miscommunication, misunderstanding, and because of those things, they accumulate into negative outcomes. Talk to us more about cultural competency from your lens.
So from my end, cultural competence has to include American-born physicians to foreign-born patients, but also foreign-born physicians to American-born patients, and American-born physicians to American-born patients who are different than themselves. And it manifested itself particularly at Kings County, in terms of being in charge of the congestive heart failure readmission prevention program. And it's tied into what I learned. And it was another stop in my tracks moment from a cultural perspective. So we went in to see a patient. I was in charge of the congestive heart failure readmission prevention, and I adopted, after I left Kings County and Elmhurst, I went to be deputy director of care management at Kings County. And I adopted the concept of the bridge team to the readmission prevention team. And it was an amazing team. We had everybody on the team. We had African Americans, we had Caucasians, we had an amazing Jewish pharmacist. We had people from Nigeria, people from the Caribbean, you name it, was on our team. And again, I went in to see a patient, and I told the team, you need to understand who's African American, who's Caribbean. And I wanted to find out, are you visiting New York and you got sick, or do you live here? Because the transition of care would be different. So we went in to see a patient, of course, Monday morning, 9 o'clock. And I said, good morning. She said, good morning. So I said, where are you from? She said, South Carolina. And from my clinical minds, I was about to say, when did you come to New York? Are you visiting New York, or do you live here? Because the transition of care would be different. And before I was able to get that question out, she said, my parents were a step away from slavery and my grandparents were slaves.
Yeah.
Monday morning, 9 o'clock.
Yeah. Yeah. Stopping your tracks moment. Right?
Yes. She said, tell me about it. She said, and some of them spoke in codes. Obviously, heart failure is age-related. Most of the patients, the cohort of patients, were between 60 and 92. And when you hear their story, and she said, my family picked cotton on a plantation that was not ours. And then we had to get up at the crack of dawn and pick 300 to 500 pounds of cotton. And then I had to walk 10 miles to a segregated school. And by the way, that number 300 to 500 pounds of cotton, I think is the same number that was in that movie, 12 Years a Slave, And I said, how do you walk 10 miles? I'm thinking, how do you walk 10 miles? We can't even go 5 blocks without calling an Uber. And I'll never forget her body language. I said, how do you walk 10 miles? She said in a higher tone, and the body language changed. Well, if you wanted an education, you had to. Like, what part of this don't you get, stupid? And then I said, did you have to walk back? She said, no, the principal in the horse-drawn carriage. And we had to get back before dark, before the Ku Klux Klan. I said, how old were you? She said, 10 years old. Could you imagine?
No, I can't.
She went to Voorhees College. It's a 2-year black college in South Carolina, in the Carolinas. I think South Carolina. And this is now almost 60 years later. And guess what her next statement was? I didn't get until my second try. She was still upset with herself. She came to New York, married. And then in the 30s and 40s was the migration. And I had to research the migration. Why is everybody from the Carolinas? Because 90% of the cohort of African-American patients were from the Carolinas. I'm thinking Virginia is sort of down the street from us. How come we don't get anybody? And just a quick note, is after the Emancipation Proclamation, when blacks had their first representation in Congress, their communities did better than the white communities. They built schools, churches, businesses. The plantation owner property went south because nobody was picking the cotton. And over the course of time, the Ku Klux Klan came in and burned the whole place down, and they came up the coastline to New York. And there's even a documentary, The Wilmington Massacre, And she came to New York. She continued her education, married, and in 30s and 40s, a large percentage of black males were either, doormen. They worked on the subway system. They worked in maintenance. And interestingly, I don't know if you ever heard of this school, Stuyvesant High School. It's the excellent school that outshines private and public schools in New York. And her 2 children were 2 of 5 black children to integrate Stuyvesant High School.
Nice.
And, I said to her, and she continued her education and became a dietitian. And she retired. I said, when did you retire? She said, in late 90s, early 2000. And I said, do you mind me asking you how much you made? She said, $200 a week, but others made more. Read between the lines. And, I said to her, it was amazing. I said to her, you're going to need, I was going to offer her home care services. And she said, I don't want anything that's not mine. And then I tell my team, if you don't communicate from what the patient thinks, apologize. Don't take it personal. So I said, I'm so sorry. Maybe I didn't explain it the way I should. She thought I was offering her a handout. And I said, patients, all patients with Medicare, home care services is part of Medicare. She said, everyone? I said, yes. She said, okay. And so when you talk about cultural competence, what I realized, the elderly black population is not a part of the cultural competence conversation. And when you recognize the role of religion in this population was pivotal to their survival, you know? And when the patient said it's in God's hands, and some of the people said, well, she doesn't want to participate in our care because, you know, blame it on God. I said, no, she truly believes it. And I went to her and said, I know God, you love God and God loves you. Would it be okay for us to help you with your medical condition so we could please God as well? And she said, Sister, amen, shall we pray? And she grabbed our hands. I'm telling you, it was humbling. And just a lot of the religion. And when the patient said on a Wednesday, she stopped eating, she stopped paying attention to whatever was being told to her, and she was depressed. And the team said, you know, she's depressed. Let's get, we have to do a site referral for depression screening, which is protocol, absolutely. I said, but find out what church she goes to and let me know. And the reason I told him to do that, I went in to see her and I said, do you mind what's important to you? And that's a key question I asked her. What's important to you? Not what I think should be important to you. What is important to you? And this was a Wednesday. She said, the fact that I will not be going to church, I may not be going to church on Sunday and I won't be able to please God. She felt guilty. The minister brought him in. The minister came in and told her, you know, even if prayed with her, and even if you're not discharged on Sunday, I will come back and pray with you. She was a different individual, you know, and it's a learning curve to understand that when you think of the atrocities that the African-American elderly endure and experience, and the fact that they have the worst health outcomes, it's unconscionable. And we were able to decrease the readmission for heart failure from 30% to 18.7 in just about 2 years. The population didn't change, the clinical care, the diagnosis didn't change. What changed was the heightened human value. Stop with the negativity in the medical records, X, Y, and to recognize these patients are human beings like everybody else. And it was humbling, you know.
I am humbled. I tell you that what you just described to us and how you got a positive outcome through cultural competency and to just asking the great question why, then being able to communicate at that level. Now, we hear from you, and I'm not hearing much of a New York accent. I'm hearing a little bit of that Jamaican sound coming from you, Dr. Beverly, but you understand all, especially in New York, such a melting pot.
Yeah.
Before I let you go, and we're toward the end of our podcast, this book is being released, I believe, on Amazon. It's Juneteenth. Why did you pick Juneteenth as your launch date?
Because it's a federal holiday. It's the end of slavery, 1865, and it's my birthday.
Oh, there you go. Your birthday. Okay. Happy birthday.
And like I say, if hospital systems adopt some of the simple solutions, because it came from patients, and currently they are not considered as part of solutions. And I look at it from another perspective, perception reality. What is the perception? You know, you hear HCAP scores, right? And HCAP scores, they do a lot of surveys. What does the patient think about the care they receive, the institutions, and so forth? But how many surveys have you heard? What does the staff think about the population they serve? And you think that could have an impact on the HCAP scores, good or bad. And I did a survey with doctors. How many are taking 5 medications, 6 medications, none, 4 medications? The most were taken were 3. And then there was one intern that was taking 1. So I said, you're taking I'm going to assume it's antibiotic. He said, yes, for 10 days. I said, are you compliant with your medication? He said, well, sometimes I forget I'm on my shift, And so I said, you can't take 1 medication compliantly, but a patient that's taking 5 or 6 medications, we now call them non-compliant. He said, well, I'm on my shift. And I said, well, patients they have shifts as well, And you know what he says? You're right. I won't use that term anymore. I will ask why. And when I do presentations at different institutions, and there's a survey, and number 7 is what I focus on. After hearing the presentation of Dr. Beverly, will it change the way you engage patients? And 90+% said yes. And I think the perception reality. So what I would recommend when I do surveys, when I hear what doctors and clinical team and executives think, I ask the patient the same question. So they say, why don't patients take their medication? And I asked the ED docs, the inpatient, the social worker, everybody said, guess what they said? Cost. Because the average heart failure patient is taking 5 or 6 medications 3 times a day with comorbid condition. And what if I told you, when I asked the patients in the bed, why don't you take your medication? What if I told you not one person mentioned cost? Guess what the top answer was? We don't take our medications because we think we're taking too many medications.
I can agree with that.
So if you're going to design a system based on cost, you see how it's going to fail.
Yeah.
And so what do we do? From the voices of the persons who are actually in the bed, we brought our amazing pharmacists in to meet with the teams to see we could combine medication. We cut out some of medication, And so
let me ask you this, Dr. Beverly.
Yes.
We're toward the end of our conversation, but I know the audience still want to get in contact with you. You have a training program. Talk to us more about your consultant business.
Yes, I do training, and I present for patient engagement and cultural competence training. And I've done it at various institutions. I've done it at Northwell. I've done it at Toro Medical College. Now I've done it at Institute of Healthcare Improvement. I've done it in Chicago. I've done it in a bunch of other places, University of Buffalo. And so that's just off the top of my head. And the whole idea is to be able to have the institutions change the culture. And the good news is we're trained to do no harm. It's not that people are bad people, but you see the changes that come about. And once you give them this particular concept, because it's not a blame game, it's about how do we better communicate, value all human beings, and improve the health outcomes. And what I do, I have demonstrable circumstances where it's proven. The bridge team is still aware, is still at Elmhurst today. Guess what? They've added a pharmacist.
See that, and to probably listening to you and some of these great techniques that you have, those simple solution. So important. If the audience needs to get in touch with you, what is the best possible way?
So at this point, I'll give you my email address. It's mbeverly, Beverley, M like in Mary, D like in David, @gmail.com. My website is being developed, and it should be available before the 19th. And it's drbeverly.com. So I'm meeting with the developers this week to finalize the website.
Excellent. Well, this has been a wonderful, wonderful discussion. I wish you nothing but the best on your release. Again, happy birthday to you. And I want to encourage your entire audience to tune into all the episodes of Follow the Brand at 5-Star BDM. And that is the number 5-star, B for brand, D for development, Infomasters.com. This has been wonderful, and I will talk to you soon. Thank you so much for being on the show.
Thank you so much, man. It's an honor. It's an honor to be on this podcast with you.
Thank
Have
you.
a good rest of the day. Okay.
Bye-bye.
Looking forward to speaking to you.
Oh, yes. Tune in for our next show or click on our website at www.5starbdm/followthebrandtv. Thank you. The Black Business Expo's mission is to raise funds for high school seniors going to college or K-12 entrepreneurs. This expo is a fundraiser for students. Please, you may go to www.blackbusinessexpousa.com to donate to the scholarship fund or use the Cash App at $BBXUSA. Our goal is to give laptops and up to $5,000 to 10 students. Students can register online at www.blackbusinessexpousa.com. Every dollar counts. Please donate to the Black Business Expo USA Scholarship Fund. Ready to elevate your brand and make a lasting impact? Dive into the world of the Follow the Brand where insights meet action. Shop now at our e-commerce store for exclusive merchandise that speaks to you. Transform, engage, and soar with 5-Star BDM. Your journey to brand brilliance begins today. Hey everyone, it's Grant McGaw, CEO of 5-Star BDM and host of the award-winning Follow the Brand podcast and TV series, where I help you to build a 5-star brand that people will follow. My genius is personal brand development through intelligent communication and helping you achieve your business and career goals. I am a requested speaker on digital technology and brand development issues. I want to work with you to increase the value of your current opportunities while attracting new ones. Every one of you is unique, and we all share challenges that can be addressed through smart branding. As a super connector, I work with you as an executive coach to guide you along the complicated business and career development road, providing the enhancement tools and information you need to succeed. Together, I will help you succeed in today's challenging business climate. I will evaluate and measure your progress. Best of all, I am right alongside you every step of the way. Build the brand called you. Genius.